Good morning, everyone, and welcome to this week's clinical meeting. We have five cases today. The first case for today will be presented by Dr. Dorene from Medicine 5, Mila.
Good morning, everybody. I'm presenting on behalf of Medicine 5. The topic I'm going to be presenting on is Mila. So looking at my case, Mr. S, he presented with complaints of ingestion of 100 tablets of an oral anti-diabetic drug on the 18th of August at around 6 p.m. There was no history of any other co-ingestions along with it. Post-ingestion, he had 4 episodes of vomiting and semi-solid loose stools. He is also a known case of diabetic with a past history of coronary artery disease. And there were no history of any similar attempts in the past. On examination, he was conscious oriented. His GCS was 15 by 15. His pulse rate was 90 per minute. His respiratory rate was 22. His blood pressure was 110/70, and he was maintaining 98% on Romer. His abdomen was soft, was non-tender. There was no free fluid per abdomen. Normal bowel sounds were heard. And cardiovascular system, his first and second heart sound were heard in the nephrology, and nephrology had agreed for plan for dialysis, and the patient was immediately shifted to ICU. So in the ward, he was his blood pressure was maintained around 110/70. So he got shifted to ICU, and with few hours of shifting into ICU, he had severe hypotension, where then he was eventually requiring dual inotropes. He was both on NORAD and vasopressin. He was also, for his respiratory distress, he was started on HFNC. He was continued his 10% dextrose infusion and bicarbonate infusion as part of the supportive management. So then nephrology had then come, and then plan for SLED was made because he was hemodynamically unstable. So SLED, he was planned for SLED, and the first cycle of SLED was given for around 18 hours on the 19th of August. And there was a minimal, so when we look at the serial ABGs, there was a very minimal improvement was there noted in the pH, but the lactate still persisted to be elevated. And so then he was planned for a second SLED, which was given for 8 hours. And post that second SLED, his slowly his pH had started improving, and its lactates levels had started coming down, and its bicarbonate was also improving. So, which is when we had looked at the main role of dialysis in metformin associated lactic acidosis. So in metformin by itself, it has a small size and it has limited protein binding. So it is actually freely diffusible through all the hemodialysis and the filters. And only limiting factor when we look at metformin and dialysis is that it has a large volume of distribution. So hence dialysis, either they'll need a prolonged period of dialysis or repeated dialysis was required. So, but when we looked at this article, so even they had suggested that hemodialysis is one of the best methods for lactic acid, metformin associated lactic acidosis. And if the patient is hemodynamically unstable, which was in my patient, CRRT is a preferred this thing. If other alternative, which for CRRT was SLED, which is what we gave for our patient. Now, lactates is usually it is not very much removed by dialysis, but a very small quantity can be removed. So then we looked at as to whether we actually had to wait till the lactates gone up to 20 as per associated lactic acidosis. So here I propose that if either there is a large ingestion or if there is elevated metformin concentration, so we do not assess metformin levels, but abroad they do assess this metformin toxic serum levels. So if there is an elevated serum level, either it is suspected or if it is confirmed, it is suggested that an early referral to an hemodialysis center to be made, so that even if the other indications that we had seen initially are not there, still to go ahead with dialysis. The main justification for it is that eventually the patient will meet those indications. So we had given 2 cycles of SLED, and coming to a patient post those 2 cycles, his pH had recovered, and then his lactates had almost normalized post this thing, and also his bicarb had also improved. His shock had resolved, and he was tapered off inotropes. He was also tapered off HFNC to room air, and he was shifted. His total ICU duration was for 4 days, and he was shifted to the ward. So looking at the prognosis, since it has a high mortality rate, this thing was that the conclusion is that the dose of metformin and the serum pH and the lactates levels, it can only indicate the severity of toxicity, but it does not indicate that it is a poor outcome, which is in contrast if the patient has a sepsis or if the patient has some cardiovascular collapse. When we think of high lactates, we think of very poor outcome, which is not the case in metformin associated lactic acidosis. So these are my take-home points: is that the main main treatment is supportive, and early RRT, irrespective of the lactates levels, is what is needed, and the levels of metformin or lactates do not indicate the mortality in Mala, and they also do not correspond to the severity of the illness.
Wait, thanks, Doreen. I'd also like to give my 2 cents on this, because this is something that a lot of our patients are on metformin, but metformin poisoning is something that is quite rare. And even among those, the lactic acidosis is not something that we usually tend to see, even though theoretically it has been explained. So this was actually a challenging case for us also, because this was probably the first time that we had encountered somebody with a serially elevated lactate, which is why now retrospectively looking at it, we know that if the lactate is serially being elevated, say from 5 to 7.6, we should have taken the patient for dialysis at that point in time. Since our experience was also very new to this, we went by the guidelines, waited till 20. So patient had to go into ICU, almost got intubated, was on dual inotropes, pH. So it's very important to understand that whenever somebody has taken more than 10 gram of metformin, if there is a serial worsening in lactate, push for dialysis as soon as possible. In that way, you will, because metformin, like she said, is a very easily dialysable component. The other thing is, normally when we say in sepsis, when the lactates are high, or in other causes of lactic acidosis, we say that anyway, no point in dialysing because lactates are not very dialysable. But in this condition is probably one of the few conditions where the lactic acidosis can be improved by dialysis, because you're actually removing the metformin, further preventing more production of lactates and thereby alleviating the acidosis as such. So, and the third point that I also want to add was, mortality in these cases do not depend upon the lactate level or the pH. So as long as you can dialyze, get the metformin out of the system, the patient has a higher chance of recovery, as opposed to sepsis where there is a chronic or a long-term tissue hypoxia that's happening because of the infection as such. Thank you, Doreen. Any questions? Sorry.
The guidelines. Any idea of the rationale why they said okay after 20? Any other points?